So if you want to take it away, Christine, it's all yours.
Awesome. Thank you so much, Mindy. And thank you, MGMA, and thank you, the Palm Beach County Medical Society. I'm really excited to present to you on how to avoid fraud in the medical practice. A couple of things we should go over first. I cannot give fraud a proper review in just about an hour. So I'm going to give you the 10,000 feet view. And one thing that we do know in this ever-changing industry is the only thing that we can really count on is change, right? So if you're reviewing this information in the future, please make sure that you're remembering to review all of the current policies, regulations, and laws. We're going to talk about that today. Many of you know me. For those of you that are old friends, thank you so much for joining me today. For those of you that are new friends, my name is Christine Hall. And the truth is that, yes, I've been in this industry for a little over 30 years, kind of hard to believe that time passed as quickly as it did. But it has been an absolute pleasure working in the business of medicine. So I've had some great experiences in compliance and coding and billing and auditing and risk adjustment. I am an instructor for the AAPC. I teach their virtual instructor-led course, and I'm also on staff at Florida Atlantic University working with their executive program. So I've had that wonderful opportunity there. And I'm going to be discussing a lot of situations or experiences that I have personally had the pleasure of being involved in, if you're picking up what I'm putting down, right? So today we're going to review fraud, abuse, and waste. And I know that those are out of the usual order, but all roads lead to fraud and then tears. And so we will discuss the laws that can lead us into hot water. And we're going to discuss the 7 elements of an effective compliance program. Notice I said program. It's a program. It's something that we do. And I'm going to refer to all of these as guidelines, because if you know me, you know I love guidelines, right? So let's have a talk about fraud, abuse, and waste. Now, virtually every week, there's a story that appears in the news, and it's concerning some sort of government investigation on healthcare providers or organizations. And did you know that behind violent crimes and terrorism, that healthcare fraud specifically is the #1 white collar priority of federal prosecutors? Recently, in an article that was published by Becker's Health Review, they actually called out South Florida as ground zero of healthcare fraud. And we've kind of made a joke about this over the last few years that, yeah, South Florida, fraud capital of the world there. But I'll be honest with you, Becker's even went a little bit further, and they identified over 13 different really notable cases that involved a Florida chiropractor, involved a South Florida marketer for Medicare benefits, involved 9 residents in Florida in a big $37 million fraud case. So we're never short of material here in South Florida to talk about healthcare fraud. And some of the examples that we're going to talk about today are from right here in Florida. So the first thing that we have to ask ourselves is, what is fraud? Okay, well, I mean, I'm sure that most of us understand the basics of what the definition of fraud is, right? But we need to understand more so what is the definition that is given to us by the Department of Justice, by the Office of Inspector General, by all of those governing entities. And the one word that is resounding is knowingly. So knowingly submitting or causing to be submitted a false claim or to make misrepresentations of facts in order to obtain payment from the federal payers that we may not be entitled to, right? Knowingly soliciting, receiving, paying, remunerations, kickbacks, anything to induce reimbursement from a federal payer. The word knowingly means either an intentional deception, maybe a misrepresentation that an individual knows, or better yet, they should know that it's false, right? And then we don't really believe that it's true. And a lot of us have been in that situation where we've seen something and it just doesn't settle with us right, doesn't pass the sniff test, right? I see you nodding, Janet. I know that you know what I'm talking about. There are a lot of examples of fraud. Charging for services that were not performed. In a recent audit that I performed, I saw a note in the medical record that said the patient was unable to leave us a urinalysis sample. So we sent her home with the cup, but they billed her for the cup, not the test, right? And so you can see where the service was obviously not provided to the patient. Unbundling. Unbundling is when there are certain components that belong in each one of those procedures that we're reporting at the same time, where we may not be entitled to additional compensation because it's already included in the original payment, or double billing for something, charging more or twice for the very same thing. There's a great example here of a provider in Stuart, Florida, which is not too far north of Palm Beach, right? And that provider was billing for items and services that were not provided as billed. I have an opinion on this, and it's simply my opinion, that a lot of times the service not being provided as expected or as billed might come from a lack of proper documentation, not necessarily that the provider wasn't doing a great job. I'm a fan of providers, not going to lie. I have a great relationship with all of my healthcare providers, and I got a lot of them, right? And I really feel that sometimes it's a lack of documentation. Upcoding. These are charging for items or services that maybe were not supported at the level that they were reported. We got to remember that the CMS manual, chapter 12, gives us a great example, and it tells us, this is the claims processing manual, and it tells us that medical necessity is the overarching criterion of payment, that in addition to the individual requirements of the CPT code, meaning the definition in the CPT book of the CPT code, it would not be medically appropriate to bill for a higher level of service when a lower level of service is warranted. The volume of documentation should not be the primary influence. So we have to remember that documentation is what really drives proof. I recently had a provider tell me that the E&M code that I put on the chart is the accurate value of my visit. And I responded, you know what? I agree. The value of your visit should be reimbursed as supported in the documentation, right? Another great example here that I wanted to share with you. A Miami doctor was sentenced to federal prison for committing $38 million in healthcare crimes. Let me tell you, friends, that when I started looking for examples to bring to you today, there was no shortage of examples. Like, there were hundreds of examples that have happened recently, just in the last few years, that maybe we didn't have on our radar, but were nonetheless very, very impressive. This was a provider who was submitted $38 million in fraudulent claims. And this was to United Healthcare and Blue Cross and Blue Shield. And with the limited amount of information I had, I immediately thought perhaps this might be related to a Medicare Advantage program because of who was involved in this. But again, it didn't state that. And this provider was submitting claims for infusions of Remicade. And Remicade is a commonly used rheumatology drug. And what he did was he hired a 91-year-old physician. Now, age is not a disease. 91 could still be very spry. My husband's grandmother is 96 years old, and she is still the life of the party. But he employed a 91-year-old physician who rarely ever treated patients, who rarely ever came in the office, to be quite honest with you, and never prescribed Remicade. And so, of course, this provider now is in hot water. So we have to be careful with the things that we do. Another example, there was a physician on the East Coast who was billing for joint injections when in fact, he was just giving B12 shots to these patients. He's now broke, and this provider is now sporting a pretty bright orange jumpsuit these days, or so I'm told, right? There's a national misunderstanding about the Medicare Incident to payment benefit. And again, if you want some examples, I highly recommend you go to the Department of Justice and you start looking at these examples of incident to. A lot of providers are still under the misconception that your contracts with payers have something to do with the way that you're licensed to perform medicine. And if you want some more information about incident to, you might want to join us on Friday as we're going to take a deep dive down that rabbit hole, my friends. This one, I can't make up. I just couldn't make it up. So last year, the Department of Justice arrested a physician that was on a jet ski on his way from Key West to Cuba, right? In 2 months worth of time, he had billed $42 million in fraudulent claims and was actually paid $2.1 million. And this was for DME supplies that were never provided. They were never requested. The patients had actually never seen the prescribing doctor, and the prescribing doctor had never ordered any of these DME supplies that the company was selling. I think, and I'm just, again, I could be overstepping, but boarding a jet ski to get the heck out of the country probably isn't going to look good. Another area of fraud that we need to worry about is misrepresentation of what was actually provided. We also need to be careful with unnecessary services. Now, for this one, I'm going to be honest, there's a lot of misunderstanding between what is good medicine and what a payer needs to pay for. A couple of examples that are coming up for you. But remember that good medicine might be ordering lab tests for all patients, regardless if they have any problems or diagnosis or signs and symptoms. And you know, maybe you don't want your patients to have to pay for these tests because, again, it's good medicine. So you just pick the most supporting diagnosis to get it paid. Notice the air quotes, get it paid. That should never be. When you have to do something to get it paid, that should give you that bright red flag. This is not cool, right? So you have to be careful with that. There is a wonderful Social Security definition of what is necessary. And I put a little link there on the bottom so you could see that link there of the Social Security. Again, it's for those illnesses, injuries, malformed body members. That's what we need. We need diagnostic testing to treat those things, but not to discover when there's no signs and symptoms. Anyway, there was another case. I know this case very well. And this case was a provider who, over the period of about 9 years, he billed $746 million. And he was paid $127 million for duplicate, medically unnecessary, very expensive tests over a period of 9 years. I can only speculate, but I believe that he probably thought that maybe since the insurance companies kept paying it, that it was okay for him to bill it. Have you ever heard that term before? Well, they keep paying me. Oh, okay. I guess he's going to have 20 years to think about that business model and see how that worked out. The next thing we need to talk about is abuse. And an abuse is not something that we may knowingly intend to do to obtain payment that we're not entitled to. Most of the time, private practices, they really do try to make sure that they are not submitting claims fraudulently. But by not understanding or by unintentionally causing unnecessary costs to the Medicare program, that's what could look like abuse. For example, billing for services that have not been properly documented. I've heard this conversation in an office. Two providers or two clinical staff or ancillary staff looking at orders in a chart and asking each other, what do you think when the doctor writes run labs? And I actually overheard a medical assistant say, I don't know, let's just run all of them because insurance is going to pay for it anyway, right? We want to make sure that we're not charging Medicare patients a higher amount than what we're charging all of our other patients, right? Things like that could be indications of abuse when it comes to payment. Another thing is submitting claims for non-medically necessary services. We have so many resources at our fingertips. We have payer policies that give us indications for coverage, limitations of coverage, and what a payer feels is medically necessary for them to pay the bill. Just like any other contract that you engage into, buying a house, buying a car, credit card contracts, right? There are terms and there are penalties of that agreement. And when providers contract with payers, they agree to abide by the terms and the policies, the rules that are instructed by that payer. While not all allegations on a provider can be founded and proven, believe me when I tell you that there are news stories like this that impact providers. They impact negatively providers, right? Perception is reality. When you turn on the news and you hear that there is a doctor who was billing for medical tests, that they were billing for services that patients didn't need or that they never even received, right? It makes us question. Imagine if this was your provider and you turned on the news or you opened up the paper or you opened up your news app, which I don't think anybody really reads the paper too much anymore. I might be one of the few that enjoy that paper. But when you open up that news app and you hear that your provider allegedly misrepresented items that maybe you had, let's say that you had a recent injection of some sort or a hearing test, or maybe you were billed for a smoking cessation counseling and you don't smoke, right? You would be questioning the ethics of your provider. So even bad publicity, even when it is unfounded or it is alleged, it becomes the new reality. One more thing I want to share with you is waste. And I have a great example. So I'm very good friends with my primary care provider. Well, I think we're very good friends. I mean, she's always happy to see me when I walk in the room, right? And if I walked in and I said, hey, Dr. B, I need a bubonic plague test. I can see her right now go, okay, Christine, tell me, why do you need a bubonic plague test? Have you been out of the country? Well, not this week. I mean, I was in California, which sometimes feels like you're out of the country, but no, it was really great, by the way. No, I haven't been out of the country. No, I haven't been around anybody that's been out of the country, and I feel great, right? So she's going to scratch her head and she's going to go, okay, Christine, why do you want a bubonic plague test? Oh, well, I was on Facebook and Facebook says that right now bubonic plague is running rampant and I should be tested. And there's a vaccine. I probably should get that too, because I don't have time for bubonic plague. Let's be honest. Right? That's a waste. It's a waste of my insurance company's time and money for services that we're not going to use to treat. I don't have bubonic plague, right? That's a waste of my insurance company's money and time. Now, it's important, and it is your job to know what the laws are. If you participate in the business of medicine, you're either paid or you're billing or you're working in administration or you're working on the clinical side or you're working in anywhere in healthcare that we are expecting reimbursement from someone other than the patient, then it's your job to know what these laws are. And I'm going to share each one of these with you, and we're going to talk about how these laws directly or indirectly affect us. The first law, the most important law, and probably one of my favorite laws, is the False Claims Act, or the Lincoln Law of 1863. So to give you a little history lesson, during the Civil War, contractors sold the Union Army decrepit horses and mules, and they had faulty rifles, faulty ammunition, rancid rations, rancid provisions. Basically, there were items that were not what the government was expecting to receive during that moment of the Civil War. And in response, Congress passed the False Claims Act on March 2nd in 1863. And because it was passed under the administration of President Lincoln, the False Claims Act is often referred to as the Lincoln Law, right? And there was also a pretty good TV show about the Lincoln. Well, maybe I'm getting those confused. Anyway, basically, this law says that you cannot submit a claim for payment for services to the federal payer system, Medicare, Medicaid, TRICARE, just to be specific, that is less than what was agreed upon. Now, remember, when we say that, we have to keep in mind all of those guidelines for reimbursement, policies, benefits, right? The requirements for reimbursement that are very well provided to us by Medicare. As a matter of fact, the Social Security Act goes on and it explains to us what a clean claim is. So a term of prompt payment is that we will submit a clean claim, and a clean claim is one that doesn't require any additional information from the provider for processing, for adjudication, for reimbursement, right? Meaning that we shouldn't have to go looking for additional information. The claim itself should provide the adequate information. Have you ever received or ever had a request for additional documentation? That's not a good thing. That's something that we need to take very seriously and make sure that we answer that request in a timely manner to support our clean claim, right? A lot of times we look at physicians and they tell us, well, when we write this, this is the standard of medicine. And everybody knows that when I say this, I mean this, or that the progression is this, or the normal treatment is this. And I'm often having to remind providers that, you know, there aren't a lot of physicians out there that spend 8 to 10 or maybe 12 years in med school to settle on a job processing medical claims. Not that there aren't any out there, and usually that happens closer to when they want to slow down in life, but nobody jumps out of med school and says, hey, I want to process medical claims for a living for minimum compensation. Not that we make minimum compensation, but compared to a physician, right? There's apples and oranges, let's be honest. I don't make a physician's salary, right? The False Claims Act talks to us about knowingly. Oh, there's that word again, knowingly. Where did we see that again? Oh, with the big F, fraud. Knowingly submitting claims or causing claims to be submitted for fraudulent or not up to par payment there. There are a couple of words here that I think it's important for everybody to know. And the first one is deliberate ignorance. Well, I didn't know. But it's your job to know. So how could you not know? Are you the one who does the billing? Then it's your job to know everything about billing. Are you the coder? It's your job to know everything about those codes, right? It's our job to know. So I didn't know isn't going to work. Reckless disregard. I don't care. It's not my problem. It's not my name on the claim form. And I've heard all of these things, my friend. And I will tell you that it is our responsibility to know the laws, to know the rules, to know the terms of the agreement and the policies and the guidelines that come with that. It means you can't bury your head in the sand to avoid liability. Here's a good example. There was a claim that was false, and it was a cardiologist who knowingly again, submitted claims for evaluation and management services, even though that evaluation and management component was already bundled into the payment for a stress test that he was billing for. that provider had to pay the government $435,000 and had to enter into a corporate integrity agreement. Oops, that's that lady again who overhears my conversations and feels like she needs to interject. You know the lady, the one on your phone or that little round thing over there. I'm not going to say her name. Anyway, corporate integrity agreement. A corporate integrity agreement is the settlement process that the government puts in place. Sometimes I kind of refer to it as a babysitting contract. It means that for a period up to 5 years, that particular provider who maybe got into some hot water, they have to be monitored on a regular basis, and monitored to make sure that all of the components of a settlement agreement are met, right? It's not enough to say we're going to do it. We need to have a corporate integrity agreement that manages it. And they often look very much like this, where they start off with the term of the corporate integrity agreement. They give you some instruction, like you have to hire an independent review organization. That's costly, my friends. I will tell you, to hire an independent review organization within 90 days of your court date, which was probably very expensive, to perform reviews and submit on any of the claims that you have submitted or been reimbursed from every 3 months for 5 years. That's costly, my friends. Another thing that's pretty costly are the penalties that are associated with the False Claims Act. So let's take one claim, for example. Let's say that you have one claim for a 99214, maybe reimbursed at $150, and you submit this claim in and it's a false claim. Well, you could be liable for treble damages. Okay, well, treble 3 times $150, that's $450. That's still not terrible, right? But then we need to look at what is the penalty, and that penalty could be up to $27,000, and then damages on top of that of up to $11,000 per fraudulent claim. Now that's a problem, my friends. Now we're looking at that one claim averaging between penalties and damages about $38,000. And if there's 10 of them, that's $308,000. How is that going to affect your staff's Christmas bonuses this year? Just thinking about that. There are also criminal implications of the False Claims Act. Physicians have gone to prison. And as we saw in some of the other examples, there was a physician who went to prison for 20 years because of false claims. Now, I get a lot of the administrative staff that come to me on a regular basis and they say, hey, Christine, we have told them over and over and over and over and over again that they cannot do this. We've showed them the policies. We have showed them the guidance. We have showed them court cases. We have shared with our providers over and over again, and they just don't listen to us. Well, my answer is, did you go to your supervisor? Did you go to your administrator? Did you go to your compliance officer and share this information with them? And if you have internally exhausted all possible resources, if you want to know what your resources are, they should be part of your compliance program, right? And still, there's no resolution. Well, the False Claims Act has a built-in clause that's the QTAM, or the whistleblower law, right? And that tells us that if we have proof, if we know for a fact of false claims, if there are payments that they were not entitled to, providers were not entitled to, or organizations were not entitled to, that they can bring charges, that they can actually act on the federal government, and they can bring charges against that provider, and they can, again, be the relator in this case, right? And they can put a case against. And recently I was listening to a presentation that Sean Wise was giving in California, and he was telling us that sometimes the Department of Justice chooses not to pick those cases up. Well, because most of the time they're understaffed, let's be honest. They can't possibly keep up with all the fraud that's going on, but the relator still has the option to move forward with this case, this whistleblower case. Oftentimes we'll see this an ex-business partner, an ex-staff member, or even patients. And I've got some examples that I'll share with you on that. One other thing, whistleblowers can receive up to 30% of what's recovered. That could be a nice little reimbursement for all those headaches from having to tell those providers. Let's take a look at this one. So there was a network of urogynecologist providers who were practicing services. They were billing the government for services that were either inflated or that they did not provide. Now, when we say that, we always think so maliciously. Ooh, they were doing something. It really could have been that the documentation just didn't support that those services were provided as expected, or that they were provided at the level that they were expected. Let's not forget that. There was actual cases where they had submitted a modifier 25, and the modifier 25 is a hot topic right now, friends. And if you go through the Department of Justice, you're going to see that it has been a hot topic for a very long time. It's not a surprise that what's going on right now in the modifier 25 world. However, they were adding modifier 25 to additional evaluation and management visits, although no additional care was actually provided. There was a whistleblower. It was a former employee, and that employee received a settlement from this case of $306,000. Let's talk about the anti-kickback statute. So it was originally passed in 1972. That was a good year, my friends. And this statute was developed to clarify fairness, right? Kickbacks, they're illegal and they're harmful to the federal government program. They can lead to overutilization of services because you are intending to get something in return. Corrupt medical decision-making. Let's go ahead and use this product or do that procedure with this product or prescribe this drug because we get money back. Patient steering. We may want to steer patients to a certain drug or to a certain specialist because we're receiving something back, or even unfair compensation. This one in itself, I could talk all day about, right? Because you have to remember that providers that are doing the ethical, that have a compliance program in place, they may not be getting kickbacks or additional reimbursement, and that's unfair compensation. Now, one thing about this is that a person need not have actual knowledge of or specific intent to violate the anti-kickback statute. So even if you didn't mean to get those bonus payments, you can still be in trouble for violating the anti-kickback statute. Kickbacks could be anything of value, could be cash, could be free rent or below market value rent. It could be free clinical staff. That word free should be your red flag, my friends. I had a provider's office a few years ago that I went into, and they said, oh my gosh, Christine, guess what? The lab gave us a free phlebotomist. She comes in here every day and she draws all the blood and we get to bill for the blood draws. Wait a minute. Are you paying for this phlebotomist? No, she's free. Okay, nothing is free, my friend. If you don't have them on staff, if they're not your employee, you can't bill for the services that they provided and get paid for it. You have no cost involved here. You've got no skin in the game, my friend. Oh. Excessive compensation for medical directorships. And there's an average out there of what medical directorships pay out. And when you see a provider who is making in the millions above what their other colleagues are making for the same roles, that's a red flag, my friends, right? Even asking for or offering a kickback could violate this law. Here's another wonderful example here. This was actually a pharmaceutical company that was in Boston, and they have a relationship with a medical practice here in Florida. And the medical practice actually agreed to pay back $130 million or $30,000 to resolve an allegation. There's that word again, allegation, right? That they had violated the False Claims Act. They received some upfront discounts for drugs, that they offered to patients, right? There was an unfair compensation arrangement there. And those compensation arrangements were not directly related to identifiable sales of the drug, right? And so the practice had to pay back $65,000 to the government and $65,000 to the state of Florida. We're going to talk about that for a second. Now, there are safe harbors that can be put in place for certain arrangements between two entities that do have some sort of a compensation or reasonable compensation set in place, right? So fair market value, services being specified, having details, having an arrangement, a contract in place that outlines all of the terms of that arrangement. Sound familiar there? There are penalties for violating the anti-kickback statute. Those penalties could be criminal penalties, and they could be civil penalties, or they could be both. And most states have an anti-kickback law. So just like the example we saw earlier, you may have to pay restitution to the federal government and to your local state. You could be in double trouble for violating the anti-kickback law. The physician self-referral statute, or the Stark Law, we use that term more often than physician self-referral, and it was really enacted in 1989 by Congressman Peter Stark. That's known as Stark 1, right? And then in 1993, there were some revisions, some changes that they added for different financial interests, and that's known as Stark 2. And that amendment became effective in 1995. Basically, what it says is that if you or a direct family member, right, have a financial relationship with another entity, another designated health service, right, that relationship or that additional compensation that you might receive from that additional relationship could be violating this statute. It could put an unfair tilt on it. And let me explain to you. So I had a hand surgery last year. And before I had my hand surgery, my hand surgeon scheduled me at the surgery center down the street. And I received a letter from the surgery center that said, hey, we just want you to know, Christine, that your hand doctor is an owner of the surgery center. So not only will he be compensated for the hand surgery that he is going to provide you, but he's also going to get compensated off the dividends of the profits and which would include the surgery reimbursement to the surgery center that your insurance company is going to give them. So in essence, your doc's going to get a little bit of an extra payment at the end of the quarter or whenever they pay out for that service that he's already been paid for. We want you to know this. If you don't want this arrangement to happen, there are 3 other surgery centers that your hand surgeon is on staff with, and we can reschedule you if you don't agree to this relationship. I like my hand surgeon. I'll be honest with you, the surgery center is down the street from my house too. So I decided to continue there, but I had the choice of whether or not. Now, the physician self-referral statute is a strict liability law. If you don't know what that means, please call my friend Jackie Bain. She'd be happy to explain it to you, which means that you don't have to have specific intent to violate the law. That's not required in order to violate the law. So we need to be really careful. What are designated health services? Kind of everything. Labs, physical therapy, occupational therapy, speech language pathology, radiology, diagnostic imaging, radiation services, durable medical equipment, parental and enteral nutrition equipment supplies. It could be a prosthetic and orthotic home health service, outpatient drug program, could be an inpatient, or it could be outpatient services. Did I cover everything? I think I did. Here is another great case where a Florida hospital system, they agreed to pay $85 million to settle a violation of the self-referral law. That it was giving bonus payments that indirectly included the value of prescriptions and tests to oncologists that ordered those, and to the hospital system was billing those to the Medicare program. They were also paid 3 neurosurgeons more than the fair market value of their work. So it means they were paying them these outrageous salaries because these neurosurgeons or these oncologists were pushing items or sales of things that were owned by that hospital system there. They had to enter into a corporate integrity agreement for the next 5 years. And there was a whistleblower, and that whistleblower walked away with $20.8 million of this settlement. Whistleblowers are often how the federal government gets the information. Now, there are some civil monetary penalty laws. Basically, it's a mandatory minimum. It says this is the punishments that must be put in place, right? So again, if we find that there is fraudulent, unnecessary procedures, unnecessary services, not only are we going to ask you for the money back, but we're also going to give you penalties, fines. We're going to have treble damages there. And you could even be excluded from participating in any of the federal healthcare programs. Exclusion of the participation in any federal healthcare program, there's two different types of mandatory or two types of exclusions. One's a mandatory exclusion. Okay, these are for people that have criminal convictions, they've done something grossly wrong, and it's mandatory that they'll be excluded. But there's also permissive exclusions there. And those permissive exclusions can be from anything from a state board suspension or a license revocation. It could be from something as simple as defaulting on your student loans or providing unnecessary or substandard care, right? And that can put you into the exclusion. Now, the exclusion is super serious, my friends. And most of the time, the exclusion is considered to be a financial death sentence, because imagine that you can't go and work at Walmart. Why couldn't you work at Walmart? They have a pharmacy, don't they? And they do accept federal health care funds for Medicare beneficiaries. Well, I'll just drive a taxi. You can't drive a taxi. Taxi companies usually have contracts with Medicaid to provide transportation services. Medicaid's a federal payer. Right now, there are almost 75,000 persons, and I'm going to explain that in a minute, persons, and 3,200 businesses that are excluded from participating in any federal healthcare program. Here is a great example of a medical biller that was sentenced to 5 years probation and 4 months in house arrest, and had to pay back $5,700 in fines, their judgment. And they were billing for services that were not authorized to be performed, or they were prohibited because some of the providers had been denied enrollment into the Medicare program or were excluded from the Medicare program. And she was directed to bill these services as if another doctor had performed the services. And both the doctor and the biller, they both knew that these claims were fraud and fraudulent. Now, I've heard this many times before. The doctor told me to bill it this way. The administrator told me to bill it this way. My boss told me to bill it this way. Well, the doc wants it billed this way, right? We need to know when this way is the wrong way, right? And we have choices to make here. It does affect all of us. Now, the federal government did step in, and the OIG, they stepped in and they said, listen, we know that even if you have a wonderful program in place to look out for fraud and abuse and waste, we know that you may not be able to always mitigate those types of behaviors. But if you have an effective means working, compliance program that predates any investigation, well, we will keep that in mind when we're thinking about penalties or charges or interest or punishment. And that came straight from the horse's mouth, my friends. Now, I think you're asking the next question. Okay, let's see. How do we implement an effective compliance program? I'll be honest with you, it's pretty easy. The OIG, starting way back about, let's say 25 years ago, give or take, They gave us some guidance on how to implement a compliance program, right? Again, it won't guarantee that we're not going to have fraud, waste, abuse, right? But it's going to help us keep a better eye on it. And we have to remember that a compliance program is not just a dusty book on the shelf, right? And we all know what that is. Everybody's got that book hidden in the manager, supervisor, administrator's office that says compliance on the bind, but we're not real sure what's inside that book. The other thing is that it is required by law. Prior to the Affordable Care Act, it was a recommendation. The OIG said, look, if you have a compliance program in place, there's a pretty good chance that you're going to catch things before they become a problem. So we recommend that you do that. Well, the Affordable Care Act says, whoa, wait a minute. If you want to participate with any federal program, Medicare, Medicaid, TRICARE, you have to have a compliance program in place. That's how we work together to avoid fraud, abuse, and waste. And now it's the law. Right? A compliance program is doing the right thing. It is required by law. It regulates billing and coding, and it prevents improper treatment and billing. It can also protect an organization by following laws and regulations, knowing what those are. It reduces denials. Who doesn't want to reduce denials in their practice? It increases billing efficiency. Who doesn't want to increase their billing efficiency? It minimizes the risk of a government audit. That we definitely want. Minimizes the risk of a substantial overpayment. And it sends a message to employees, providers, and others that our practice has an ethical, law-abiding organization. Do you remember your first compliance meeting? It probably you were about, let's say, 8 or 9 years old, right? And you got an introduction to the chores, AKA the house policy. Everyone will clean your room. And your mom or your dad or your grandparent probably stood there and gave you a nice little tutorial. We're going to take everything off the floor, laundry into the laundry room. We're going to change the sheets on the bed. We're going to vacuum the floor. And that's what we're going to do. That's the procedure of how we're going to do this. And then you probably had a little bit of monitoring that was happening. I'm sure mom or dad peeked their head in and said, okay, you're doing a good job, or don't forget this, right? And when you came and you gave that big announcement, I'm done. They came and they audited your work and they saw what you were doing and they gave you some education and they said, you know what? Let's get everything out from underneath the bed and put that in its proper place too. And they also warned you that if you don't do this correctly, that there are going to be consequences. However, if you do it correctly, there could be some rewards. Bet you didn't know that you've been participating in compliance your whole life. Now, the OIG has outlined 7 elements of an effective compliance program. And these might sound a little bit familiar based on our past conversation. It means that we need to have some standards of conduct, policies, procedures. We need to make sure we have trustworthy individuals that are in our environment there, that we have internal monitoring and auditing of what we're doing. So we know we're doing it right, not we think we're doing it right. Communication and education. We want to make sure that those that don't understand, that we help them understand. There's some reporting and investigating. Did we do it right? There's some response and prevention, and that could be, there's a better way to do it. So let's try this. And then, of course, you're always going to have those bad actors. So there will be enforcement and discipline. And under these pillars, we're able to mitigate all of the alphabet soup organizations, the Department of Justice, the Office of Inspector General, the Centers for Medicare and Medicaid Services, or the Federal Bureau of Investigation. Policies. Policies are the standard. This is what we do here. This is how we do it. That's the procedure of how we do it. And you probably have a lot of policies that you're not even aware of. Policies on auditing and collections and corrective actions, maybe even employment policies. Those are really important, guys. Employment policies, how we get paid, big fan. You also should know who your compliance committee is, or at least who your compliance officer is. And a compliance officer really, when they belong to part of a committee that includes people from different areas of the organization, practice manager, billing manager, clinical manager, a physician liaison, all of those individuals, they bring a different perspective to the world of compliance or to our compliance program, right? Communication and education. We want everyone to make sure that they feel like they can come and talk to supervisors, managers, administrators, compliance officers. They can ask questions, they can report problems, right? The compliance officer can look at policies and maybe make some revisions or offer some clarity there. We also want to make sure that we're getting some good education every year. And if you'll notice, I think that training for new employees is always important, not just on the OSHA regulations or not just on employment policies that are in the practice, but also any other area of the practice where we have policies, billing policies, coding policies, documentation policies that impact that employee. And we should refresh the training annually. There's something about repetition that works. And I recommend that you have an annual coding update education. What are the procedures that we do in our office? What are the codes that we're reporting? What does that documentation look like? And everyone in the practice should be involved. Internal monitoring and auditing. Now, there's a big difference. If you asked my friend Frank Cohen about auditing, auditing is very strategic. It requires a statistical sample, and there are different types of statistical samples out there, and they're very official, and they tell us whether there's an overpayment. While monitoring is something that we can either do internally, we could bring someone in externally without bias to take a look and to identify opportunities to improve our practices, improve our documentation, improve our operations in general, whether it be revenue cycle, whether it be a template that we're using. Template's just a tool, friends, right? And we must be actively doing that on a regular basis. Now, one of the things that I love to do when I go in and I do monitoring, or if I have to do an audit, is I like to look at what the other regulatory agencies are looking at and see if any of those are services and supplies that we provide in our organization. So if the OIG on their work plan have something on telehealth and we provide telehealth, well, I want to know what they're looking at and what they have found so that we can make sure in our practice we're being compliant. Again, we have those responses. Responses are so incredible because that's where change really happens. Is it that maybe the policies and procedures that were written 20 years ago need to be updated, right? Maybe we're not handwriting notes anymore. Maybe we're using an electronic medical record. Maybe we're not typing medical claims out. Maybe they're being submitted electronically now. We need to look at those policy and procedures and see where we can be better. We want to make sure, because that helps retain staff. I mean, you know, as an employee of an organization, it's always comforting to know what's expected of you so that you can set a personal goal and you can go beyond that personal goal there, right? And what will happen if I don't do it right? Are those corrective actions, are those consequences appropriate today? What do they look like? And do we have to do overpayments and refunds when we find something wrong? Or do we need to call our healthcare attorneys? We want to encourage all employees to raise any concerns so that we can investigate. If you see something, say something, and remind them that there's zero retaliation, that we want you to say something. And even though your friend might get mad, if she takes your parking space because you told, well, that's okay. We'll find you another one. There are so many different issues that we need to be aware of. Conflicts of interest, embezzlement or fraud, kickbacks, ethical standard violations, medical billing irregularities, billing for services that were not rendered, falsifying claims, or receiving an overpayment and not returning it. Remember, when we receive something or we have something that doesn't belong to us, we need to return it. I recently talked to a group and I said, what would you do if you came to work on Friday and you noticed that there was $10,000 added to your paycheck that you had no idea was going to be there? Would you keep it, or would you run into the office and say, whoa, wait a minute, there's $10,000 on my paycheck that I was not expecting, and I need to know, is this mine or is this an error, right? And better you say something than HR come back to you. So we want to make sure, not just HIPAA and not just privacy rights, that we are communicating in that office, whether it's a hotline that you have available or you're talking directly to the compliance officer, your supervisors. And know that sometimes we're going to have bad actors. Know that sometimes people are going to get the message and ignore it, right? And when that happens, then we need to impose some disciplinary actions to protect everyone in the organization there. So if we have non-compliance or failure to comply, we could have some change in staff or worse. Now, I always found this to be extraordinarily ironic. 25 years ago, the OIG published in their guidelines for small practices the following risk areas. And they said that some of the risk areas that they saw 25 years ago were for billing for items and services not provided, submitting claims for equipment, medical supplies, and services that were not reasonable and necessary, double billing, billing for non-covered services as if they were covered, knowingly misusing providers' identification numbers. That's a great topic of conversation. Billing for unbundled services, failure to properly use coding modifiers and upcoding, right? So today we kind of talked about how to avoid fraud. We talked about mitigating fraud, abuse, and waste. We talked about the laws, and it's your job to know the laws. And we talked about implementing an effective compliance program. A program should always be a working program, not something that will ever be done. It will always be moving and improving, right? Mindy, do we have any questions?
I don't have any questions in the chat box. But does anybody have any questions? If you want to raise your hand or
Unmute yourself. Can they unmute
Yes.
themselves?
all I have is, hold on. Everybody telling me how awesome you are, Christine, of course.
Thanks. I appreciate that. Oh, Nina corrected me. It was the Lincoln lawyer, not the Lincoln law. Thanks, Nina.
And just to let everybody know, I put Jackie Bain's email in the chat box. So if anybody wanted to reach out with a question. Christine, you were amazing.
Thank
Always
you.
so informative. I really appreciate it.
It's my pleasure. Absolutely. It is unfortunate sometimes that I do get called only when the red flag goes up. It would be awesome if I got a call, or if some of my other consultant colleagues got a call before the red flag goes up, that we could do some more proactive work. The reactive work, honestly, is heartbreaking. Proactive work, bringing us in before that happens so that we can help you, we can stand with you in building your compliance program and avoiding a publication, avoiding a headline, avoiding being in the news, right?
That's true.
Hey, Christine, Slady, I have a question.
Sure.
Always having questions, right? Okay, so you talk about the whistleblower. If the whistleblower become a whistleblower, is that going to hurt you later on if you become a whistleblower in your future? Like if you are working in the healthcare, like to get another job, is that going to hunt you down?
Well, the official answer is it's not supposed to. The
Okay.
unofficial answer is, I have a friend of mine who was a whistleblower, and we live in a very small community, and word traveled fast, and it was difficult for her to find a job. Now, this was, in all honesty, it was 15 years ago, and things do change. And we are seeing this more often, that where employees have gone to the right people over and over again and have shown the documentation, that have shown the policies, the guidelines, and they don't hear from anybody. I think that one more word, this is a personal recommendation. Before you decide that you're going to whistleblow, reach out to a healthcare attorney. Call Jackie. She's going to guide you whether or not this is something that has teeth or doesn't have teeth. That way, you don't put yourself out there, and then maybe it is truly a misunderstanding, right? And we would hate for that to affect you in that way if it was truly a misunderstanding. So my go-to answer is call Jackie. I mean, call your healthcare attorney, to be fair to the other healthcare attorneys. She's not the only amazing one. Her partner, Michael, is amazing as well, right? But again, just saying, it's important that we communicate with our healthcare attorneys. You know, they really do have our backs. They're really working with us. So I hope I answered that for you, lady.
Yeah, you did. It's always good to know that, right?
It is. It is. Just a few little things here to remind you that you can reach out to me anytime. Please do. If you have any questions, if I can help you or your organization with your compliance program, or if you've received an additional documentation request, a target probe and educate audit, anything that I can help guide you and walk through with you, you need a recommendation for a healthcare attorney, please reach out to me. This is my direct email. I will answer you back. Want to also invite you all on Thursday mornings to join me for my podcast, Coding with Christine Hall. This week, we're going to have the great Terry Fletcher with us talking about the sections of ICD-10 guidelines. And we have a membership program that I want to invite all of you to check out and see if this is something that can help you. Lots of Q&A answers there, a lot of resources, a lot of on-demand webinars, things of that nature. So that's all I got, Mindy. Thanks so much, everyone. And thank you for your time.
Christine, thank you so much. You were super awesome and always informative.
Thank you.
Thank you everyone for attending.